All right. Hello, everybody. Thank you for having me again to speak this year. So my name is Sarah Vanderberg. We are going to be going through the Fast Five updates of hematology pharmacy. Currently, I practice at Baptist Cancer Center in the Malignant Hematology and Cellular and Gene Therapy Clinic. So let's get started. All right. So here are the objectives for today. We will be discussing the new fixed duration oral therapy for CLL and how we can apply this to practice. We'll also be examining a novel treatment for ITP. We're going to analyze the potential of BTK inhibitor use in upfront setting for mantle cell lymphoma. And we're also going to be talking about the new bispecific for relapsed and refractory multiple myeloma. And then to top it all off, we're going to highlight notable developments in the FDA pipeline for oral oncolytics specifically. First, we're going to be discussing Bruton tyrosine kinase inhibitors, also known as BTK inhibitors. I feel like this past year, it was a big year for BTK inhibitors. We had quite a few approvals, and we're only going to touch on 3 of them today. So acalabrutinib or Calquence received 2 novel approvals within the past year, specifically in the mantle cell lymphoma and CLL space. And there's also a brand new BTK inhibitor being used for the treatment of ITP, which we will also discuss. First, we're going to talk about acalabrutinib in CLL. The results of the Amplify trial were discussed at ASH last year, and they were published in the New England Journal of Medicine in February of this year. The Amplify trial was a randomized open-label phase 3 trial in therapy-naive CLL patients who had an ECOG score of 2 or less. This trial evaluated first-line and fixed-duration therapy utilizing acalabrutinib plus venetoclax with or without obinutuzumab for a total of 14 cycles. This was compared to the investigator's choice of chemoimmunotherapy, and crossover in the study was not allowed. Additionally, I think it's important to highlight that the trial excluded patients with the deletion 17p or TP53 mutation. And this is because we know in this population, unfortunately, chemoimmunotherapy is not as effective as other treatment modalities. The combination of triple therapy with acalabrutinib, venetoclax, and obinutuzumab reduced the risk of disease progression or death by almost 60%. It was 58%. And this was compared to the chemoimmunotherapy arm. And this was found to be statistically significant in the analysis. After 41 months in the median follow-up, the study also found that the all-oral regimen, so venetoclax and acalabrutinib, reduced the risk of disease progression or death by 35% compared to the chemoimmunotherapy arm. However, median progression-free survival was not reached for either experimental arm. In the interim analysis for overall survival, the data demonstrated a favorable trend, which was significant for the all-oral regimen. However, like with all BTK inhibitors, there are some safety considerations that we need to, take a closer look at. So there's some extra precautions that need to be highlighted that can help manage these patients that are receiving triple therapy. So for instance, there were a higher number of any type of serious adverse events that were observed in the triple therapy arm compared to the other 2 arms of the study. And there were also higher rates of cardiac events that were seen in the triple therapy arm. And then I don't think this is too surprising, but the chemoimmunotherapy and triple therapy had higher rates of neutropenia as well as infection. So what did NCCN say about this? As a result of the study, the combination of venetoclax, acalabrutinib with or without obinutuzumab is a preferred category 1 recommendation in patients without TP3 mutated CLL. But what's interesting is they also highlighted this in the TP3 mutated population. So in patients who did have this mutation, we know they were not enrolled in this trial because the control arm included chemoimmunotherapy, which, as I've already said before, is not recommended in this population due to low response rates. However, in a phase 2 study, the combination of venetoclax, obinutuzumab, and acalabrutinib resulted in an overall response rate of 98%, and it resulted in 71% of those patients achieving a complete response who had this mutation. So given the available data, the committee for this disease state, listed it as a preferred BCL2 containing regimen for patients with this mutation. Next, we're going to be talking about a new BTK inhibitor. It's called Medieiros, and this is a novel BTK inhibitor used to treat immune thrombocytopenia. In August of this year, the FDA approved this drug for patients with persistent or chronic immune thrombocytopenia who had insufficient response to at least one previous treatment. And this approval was based on the LUNA-3 study, which we'll talk about in a little bit. All right, so obviously I'm a pharmacist. We're going to be talking about the mechanism of action because I do think it's important for understanding this drug. So this is a novel mechanism in that it selectively and reversibly inhibits BTK. So this is a covalent and a non-covalent binding, and it increases the selectivity while decreasing off-target side effects that are associated with this drug class. So by binding to BTK, it inhibits phagocytosis as well as preventing B cell activation against platelets. All right, just gonna highlight some key points of the LUNA-3 trial. This trial had a primary endpoint of significant durable platelet response by week 25 of treatment. And this was defined by the investigators as a platelet count of 50 or higher for 5 out of 8 weekly lab measurements. And the trial found that patients in the treatment arm had 7 weeks of platelet response compared to less than a week for the placebo arm of the trial. But in patients who were considered responders to the treatment, this number increased to 11 weeks. And then another outcome that they looked at for the trial was the time to first platelet response. And this was 36 days in the treatment arm, but it was not reached in the placebo arm, which again, I think makes sense. But in patients who were considered responders, this number was even less. It was a little over 2 weeks, which is pretty impressive. All right, last but not least, we're going to be going back to acalabrutinib. We're talking about Calquence again, but this time we're going to talk about it in the setting of mantle cell lymphoma. So previously, we know that the combination of ibrutinib with bendamustine and rituximab for the first-line treatment of mantle cell lymphoma, it prolonged progression-free survival, but the overall survival had no impact, and this was likely due to increased toxicities. So acalabrutinib is a second-generation BTK inhibitor with less toxicity compared to ibrutinib. So we'll be discussing the ECHO trial that looked at this combination, which was presented at ASH and published in ASCO. All right, this was a pretty large trial. It had almost 600 patients that had previously untreated mantle cell lymphoma. And there was no intention to take these patients to autologous stem cell transplant. So they elected for less intense therapy, although this regimen can be pretty intense for a lot of patients. And they were randomized 1-to-1 to receive BR with placebo or acalabrutinib. And this treatment was given in perpetuity or until disease progression or unacceptable toxicity. Crossover was allowed in this trial. And the primary endpoint was progression-free survival. Secondary endpoints included overall response rate, overall survival, as well as safety data. All right, looking at the primary endpoint of progression-free survival, this was found to be statistically significant in favor for the treatment arm, being 5.5 years compared to a little over 4 years in the placebo arm. Looking at duration of response for patients who did respond to treatment, the median duration of response was 64 months compared to 54 months in the placebo arm. For overall response rate related data, 91% of patients in the treatment arm did respond to therapy compared to 88%. And then 67% of patients in the treatment arm had a complete response, while 54% in the placebo arm had a complete response. However, this was not statistically significant. In addition, overall survival was not significantly different between the treatment arm and the placebo arm. You can see the Kaplan-Meier curve is pretty similar for both treatment arms. However, despite this, NCCN has acalabrutinib with BR as a preferred regimen for induction therapy in MCL patients. I do find this approval and guideline update somewhat surprising. As you can see based on the trial results, they didn't demonstrate a major clinical benefit beyond progression-free survival, which we know in oncology, we're using that as like a surrogate endpoint for overall survival. But that being said, I think given how difficult mantle cell lymphoma is to treat, even with incremental gains, it may represent meaningful progress in patients. All right, yay, a new bispecific for myeloma. Yep, there is another one. So in July of this year, the FDA granted accelerated approval for linvoseltamab. And this indication is already similar to other bispecifics that are already on the market. So just a reminder, it's going to be your relapse refractory myeloma patients that are status post 4 lines of prior therapy, and it had to include a proteasome inhibitor, immunomodulatory agent, and an anti-CD38 monoclonal. And this was approved based on the linker MM study, which we're going to discuss in a later slide. But again, we're going to talk about pharmacology a little bit first. So this drug is a BCMA and CD3 targeted bispecific T-cell engager, and it's similar to elranatamab and teclistamab. However, it is given as an IV infusion as opposed to an injection like the other two. And there's also some key differences in inpatient observation that I'm going to go ahead and highlight now. That way, the dosing, when you're looking at the dosing for this drug, you have some context for what we're looking at. So with Tecvayli, it's recommended inpatient observation for each step-up dose. So that's a total of 3 inpatient stays that are recommended. Elranatamab, it's recommended for 48 hours after the first step-up dose and then 24 hours after the second step-up dose. So that's a total of 2 hospital stays. And then for the new guy, it's recommended for 24 hours after the first step-up dose and then 24 hours after the second step-up dose. So that's, again, a total of 2 hospital stays. All right, so this is where it's different. So we're going to talk about the dosing considerations. So for days 1, 8, and 15, it's given as a 4-hour infusion. But keep in mind, patients do require pre-meds that are given at least an hour prior to this. So it's a long time in the infusion chair for those first 3 weeks at least. Day 15 is the first treatment dose. It's 200 milligrams. And then on day 22, if day 15 was well tolerated, then the infusion can be reduced to be given over 1 hour. And then subsequent infusions after that can be given over half an hour as tolerated. So again, it's all up to how the patient can tolerate it. So it's given weekly until week 14, and then it may be reduced to be given biweekly thereafter with the option of going to once a month if the patient has achieved and maintained a very good partial response or better after week 24, and they've received at least 17 treatment doses. So you might be thinking to yourself, especially compared to the other BCMA targeted bispecifics, what's the point of this? And the angle that the drug company is getting at with this therapy is to reduce the total number of visits to infusion centers for patients who respond to treatment. So it's more of like a big picture, not necessarily, in those first couple of weeks where the infusion is 4 hours long. Next, we'll discuss the linker trial. So this was an open label, multi-center, multi-cohort trial that included patients who had previously received at least 3 prior therapies. And again, they had to have had a proteasome inhibitor, an IMiD, and an anti-CD38. And then they also had to have an ECOG score of 0 to 1. This trial also excluded patients who had prior BCMA exposure, whether that came in the form of CAR T or another bispecific. And they also excluded patients who received any prior bispecific therapy. For the intervention of the phase 2 portion of the trial, patients received either 50 milligrams or 200 milligrams given weekly through week 14. And then they were transitioned to biweekly on week 16. And then specifically in the 200 milligram cohort, patients could transition to every 4-week dosing thereafter. So very similar to what's in the package insert already. Primary outcome was overall response rate. Secondary endpoints included duration of response, MRD, overall survival, and progression-free survival. Overall response rate was 70%, and estimated duration of response was 89% at 9 months, and then 12%, or excuse me, 72% at 12 months. 64 patients achieved a very good partial response or better. And one thing I like that they did in the study is they did a post hoc analysis with the CR rates, and they actually increased from 45% to 51% with longer follow-up. Again, like with other bispecifics, CRS and neurologic toxicity are always going to be a big concern, in addition to infections and neutropenia. For CRS, most events were a grade 1 or 2, with the median time to onset being approximately 11 hours after that first dose. 38% of patients had an event after step-up dose 1. For neurologic toxicity, this occurred in 54% of patients, and ICANS occurred in 8%, with a median time to onset being 1 day and the duration of symptoms lasting around 2 days. The greatest risk of infections occurred within the first 6 months that you can see from this chart here. But as you can see, similar to other bispecifics currently on the market, the risk is still very real the further out from therapy that they get, or I guess the further out from induction therapy they get. And the most common serious infections were pneumonia and sepsis. And then grade 3 and 4 infections occurred in over a third of all patients. So this is really where, again, prophylaxis is so important. So they recommend PJP and viral prophylaxis for the duration of therapy, and to consider using antibiotics and antifungals for neutropenia, with a special consideration for prolonged neutropenia by using a mold-active antifungal. And then, of course, IVIG replacement to help hopefully prevent some of those infections. So as a result of this trial, linvoseltamab is considered a preferred therapy for patients with multiple myeloma after at least 4 lines of prior therapy, just like the other guys that are already on the market. All right, last but not least, we're going to talk about some of the up-and-coming therapies. One that I found really interesting, in particular because we're already doing this at my practice, or we have done this previously at my practice. It's an all-oral therapy for newly diagnosed AML. We mainly do this for patients who have to travel pretty far to our clinic for treatment. So if that's like a big burden for patients, we'll consider using this in the frontline setting, especially if they're not a candidate for intensive chemo. So specifically using Inqovi, which is decitabine and cedazuridine with venetoclax. Currently, Inqovi is approved for MDS as well as chronic myelomonocytic leukemia. And the trial that is investigating this all-oral combo for newly diagnosed AML is the Ascertain 5 trial, which hopefully will have some more results in this, hopefully by the end of this year. And then the other drug that I found interesting that's in the pipeline right now, I feel like menin inhibitors are still a really hot topic this year. One that's currently being investigated is ziftomenib, and this is for relapse refractory AML with NPM1 mutation. All right, and that's all I've got. I'll be happy to answer any questions.